Good evening, sir, and good evening, everyone. So, Indian Academy of Cerebral Palsy, on which platform we all are joining today, I'll be introducing that today. Indian Academy of Cerebral Palsy was established with the primary mission to propel perceptions of disability from a label to the empowerment and enablement of ability to achieve inclusion in all the streams of life. The academy is growing very fast over the years, fulfilling its objectives by large number of eminent professionals with national and international reputation since 2004. The Indian Academy of Cerebral Palsy is a reputed academic body in the country, having highly respected professionals as its members, providing an excellent forum for the academicians and rehabilitation professionals to put forth their wisdom and to enrich their knowledge for better delivery of education, patient care, and sensitization of civil society at large. The Academy has risen to glorious heights ever since its inception, and the same as also knowledge by the international professionals. Under the able leadership of our IACP President K.D. Mallikarjun sir, many teaching programs are being organized. All of our teaching programs that will provide great opportunity for fruitful deliberations and enrich the knowledge of young professionals of this field and provide interaction with one another and experts in this field to improve the status and quality of services in empowering the persons with cerebral palsy of the country as a whole. We all are in this webinar because there is new knowledge to be gained and that knowledge to be used by all of us for rendering quality services for welfare of the families and persons with cerebral palsy. Thank you, sir. Now I request Dr. Maulin, sir, to please introduce the moderator for the today's session. Thank you, sir.
Thank you, Lakshit and Dr. Mallikarjun and IACP for giving me the opportunity to introduce Dr. Dhiren Ganjwala. It's a privilege for me because two of my mentors are going to speak today, Dr. Unni and Dr. Dhiren Bhai. Dr. Dhiren Bhai doesn't need any formal introduction. We all know him. He's a pioneer of cerebral palsy orthopedic surgeries. And by his collaboration with the doctors across the world, he has brought in latest knowledge in the cerebral palsy surgery to India. He was past president of Pediatric Orthopedic Society of India, and I have known him since I was an orthopedic resident and learned visual gait analysis from him. However, I was a bad student and kept on forgetting what he has taught me. And so I love to hear him again and again and to learn the intricacies of cerebral palsy. And then I had an opportunity to learn the principles of management from Dr. Unni at Sikit. So I'm very happy to share this Zoom platform with these stalwarts. And Dhiren Bhai, welcome and kindly introduce our honorable speaker, Dr. Unni Narayanan. Thank you.
Yeah, thank you, Dr. Maulin, Dr. Lakshit, and the President of Indian Academy, Dr. Mallikarjun. It's a privilege to introduce the esteemed speaker for today's session. Professor Unni Narayanan is a consultant pediatric orthopedic surgeon at Sick Children Hospital, the very famous children hospital of Toronto, Canada. A very busy practitioner, but over and above that, he has many leadership roles. Dr. Unni served as the president of American Academy of Cerebral Palsy and Developmental Medicine for the year 2016-17. He also served as the director at Pediatric Orthopedic Society of North America, that's the POSNA. He has been recognized with several awards, including the McKeith Press Young Investor Award from American Academy in 2005. He is also involved in research focusing on patient priorities and designing outcome measurement tools, particularly in the context of cerebral palsy. He has also led many international studies, such as the CP-HIP study, which actually evaluates what is the outcome of these surgeries. Dr. Unni has been invited as a visiting professor worldwide to present his research and share his vast experience. Indian Academy of Cerebral Palsy is really thankful to him for accepting our invitation and presenting his views on the topic which is very close to his heart and also to his mind. Now, before we listen Professor Unni, let me give you why this topic is important and why we decided to keep a lecture on this. For ambulatory children, we use gait analysis for decision making, which is a standard practice for all of us. Today, we are going to learn about a very different perspective, and that is GOAL. And GOAL is an acronym of Gait Outcome Assessment List. It captures the child's and the family perspective on what matters most regarding mobility and walking ability. Why this is important in present era? Because for last few decades, we try to adopt a patient-centric approach. And in that, we offer treatment as per the requirement of patient and family. And for this to happen, we need to understand their problems and what is required by them. It's not important like what we know and what we want to offer. So this gait outcome assessment list assess the child from that perspective and help us to decide what is important for child and for the family. So with that background, I now hand over to Professor Unni Narayanan for his elaboration on the topic. Over to you, Unni. Thank you.
Thank you, Dr. Ganjwala. First of all, that's a wonderfully kind introduction, and thank you so much for the invitation to give this presentation. I'm particularly grateful and honored that the Indian Academy of Cerebral Palsy is hosting this event. Thank you to Dr. Mallikarjun and Dr. Lakshit Doshi, and of course to Maulin Shah. It is a real privilege to do this, and I am looking forward to the next little while, and hopefully there's opportunities for discussion at the end of my talk. So, greetings from Toronto, but I'm actually sitting in Chennai in South India. I'm in Madras in my parents' home where I'm visiting for a short period of time. And this is a beautiful photograph of Toronto at the skyline taken at night by a friend and colleague, a pediatric orthopedic surgeon and a very skilled photographer, Dr. Vijay Sriram, who is actually located in Chennai. And this is a photograph of my institution, the Hospital for Sick Children in Toronto. I'm obligated to share that I have really no financial relationships to disclose, but I've got lots of acknowledgements which I will make at the end for the work that I will be presenting. Before I tell you what I'm going to talk about, I thought I should set the stage by introducing you to somebody to provide a little bit of context of why we're talking about the topic of the day. Let's meet David. He's 12 years old. He's twin. He's an ex-preemie. He functions at a GMFS level 3. He walks with canes at home. He uses a walker at school and in the community. But over the last year, he's been experiencing some knee pain, more fatigue. He's tripping frequently. He wears airfoils or braces that he doesn't like. He's very self-conscious about them, and he is less tolerant of them. He feels excluded, especially in Canada during the summer, which is the best time of the year. You know, his twin brother is out in camps and having a good time, and he's spending all that time doing therapy and exercises. He's finding it difficult to keep up with his friends. And in the last year, he's now relying more on a walker. Okay. His parents have come to see, are seeking opinions. They want David to walk better, and they don't want him to have to use a wheelchair. Okay. So David has access to good care. They seek multiple opinions and ultimately come to a multidisciplinary clinic where he gets evaluated and a recommendation is made. So he gets the typical visual gait assessment, and he's seeing that he's walking on his tiptoes in a typical equinus pattern. His legs are rotated internally and his knees are rubbing against each other. His knees are quite flexed. He's dragging his feet. He's got quite poor balance. He walks quite slowly, and he's relying quite heavily on the walker to support himself. When you do a physical examination to explain the gait observations, you find that he's got some generalized high tone in different muscle groups of his lower extremity, typical spasticity, that's velocity dependent. He has some fixed contractures of the knee and of the ankle, and he's got a torsional deformity of the femur that explains that internal rotation gait that he's got. So based on this, he undergoes a 3D gait analysis in a motion laboratory where we were able to sort out some of the nuances of his gait. And based on that, a recommendation is made for multi-level orthopedic surgery, which after a lot of time and consternation, because they know this is a big undertaking, they agree, and he has a surgery in order to improve his gait. So 6 months after, and he's had extensive physiotherapy, he's now walking with his feet flat on the ground. His feet and his knees are pointing straight ahead. He's standing taller. His knees come to full extension during down space. He's no longer in that crouch pattern. His knees are not rubbing against each other. He's stopped tripping, and therefore he's not falling. And his knee pain has resolved. But he's still using a walker, both at home and in school. And he has to use a wheelchair outdoors, which he was not using before. He has hypersensitivity in his feet. So he's lost his knee pain, but in his feet, he's got a lot of dysesthesia, tingling and numbness, which makes it difficult for him to wear his shoes, but he has to use their force for support. His walking speed has declined in the first few months after surgery, and his endurance has actually decreased. But more recently, it has improved and has reached his baseline, but not exceeded his preoperative level. Okay, this is fairly common. He's also missed 4 months of school in the last 6 months. So, has the intervention made David better? Was the right decision made? Well, it all depends on how we define better and how we make decisions. You know, how should we make decisions about making an intervention depending on those goals? And here is a quote from the mother of a child who was 8 years old and faced with this very challenging situation. And what she said, as a layperson and a mother, it was almost an impossible challenge to wade through all the medical research on selectal dorsal rhizotomy and simultaneous lower extremity, multi-level lower extremity surgery, and make a decision that would impact my son for his lifetime. How does a parent decide which invasive surgery will be most effective to help a child with the least risk? There were a lot of sleepless nights and much angst. My son was a candidate for both procedures, and our doctors and therapists were not in agreement. More evidence-based research is needed to help parents and medical practitioners help kids with cerebral palsy have the best outcome with the least amount of pain and risk. Okay? So this was something that I encountered fairly early in my practice, which then became sort of the principle or the theme of what I was interested in researching, which is defining better and trying to answer the question, are we actually making a difference to our patients? During my presidential year at the American Academy at my annual meeting, that was in fact the theme of the meeting, making a difference, but with a question mark. Are we actually doing that? And so I set about to try first and foremost to understand the priorities of my patients and their parents, arising from their personal lived experience. And with that information, incorporating those priorities and goals in the development of meaningful outcome measures that are patient reported, that capture what's really most important to them. And then applying these PROMs, as we call them, in clinical trials or cohort studies to really judge the effectiveness of the interventions of these conditions. And more recently, to try and figure out how we can actually use these PROMs, not just to determine whether a treatment A is better than treatment B or compared to natural history, but to actually help with making decisions and shared decision making. So that's what this talk is about. What I'm going to try and do in the next 30 to 40 minutes is, what are meaningful outcomes? I'm going to introduce you, perhaps you are already familiar with the ICF model that has been used to conceptualize outcomes, and introduce you to the concepts of quality of life and health-related quality of life. I would also like to share our framework of patient priorities to understand what's important to patients, parents, and families, and use the goal as an example of how we then developed and validated a patient-reported outcome measure for ambulatory cerebral palsy for children like David, and how we're using that prompt to elicit patient and parent goals for decision-making. So that's the goal of this talk. Okay. The phrase evidence-based medicine, you're all familiar with. It is about the use of the current best evidence in making decisions about the care of individual patients. This was coined by David Sackett back in the 80s. And evidence-based medicine, we know, integrates the best available external evidence from systematic research. But there's a second pillar, and that is it allows it to incorporate or integrate individual clinical expertise. So there's a room for the judgment from clinical experience and clinical practice of clinicians and physicians. That is one source of that evidence. But what is often forgotten is the third pillar of evidence-based medicine, and that is the incorporation of patient preferences while making decisions about them. And there's been an evolution of patient-centered care with interest in patients' perspectives that's now widely accepted. It was music to my ears to hear, the mission of the Indian Academy of Cerebral Palsy, which reflects exactly this concept. And outcomes research is really this whole system to work out what works in medicine and to learn how to make clinical decisions that reflect more truly the needs and wants of individual patients. And if that is true, the success or the effectiveness of our treatments should be judged using meaningful outcome measures that reflect those goals and expectations of individual patients. And if that is important, then they have to be patient-reported. I cannot tell somebody whether the outcome is good or not. It's up to them to make that judgment for themselves. So what are outcomes? Outcomes are what happens after some treatment or after the passage of a certain time. We call that natural history. And that outcome can be desirable. That's something that we are hoping for. It can be undesirable. There can be complications, side effects, there can be adverse events. And outcomes can occur early, they can occur interim or late. And a successful outcome, if we think about it, I think we can all agree, is one that achieves the goal for which that treatment was intended. And that goal, it can be really of two different kinds. It can be prophylactic or reactive. So when we say prophylactic, we're saying our goal is to prevent something bad from happening in the future. Reactive in the sense that we're trying to address a problem right now and perhaps to prevent a problem in the future. But whose goals are we talking about? Are we talking about the patient's goals? Are the parents' goals? Are we talking about the clinician's goals, or a combination of all these things? And essentially, outcomes research is a science of measuring effectiveness or success. We actually have a very robust and holistic framework to understand outcomes in general. And this is from the World Health Organization, the International Classification of Function, Disability, and Health, or the ICF model. At the top, you've got the condition of interest, in this case, cerebral palsy. And that condition is associated with a particular problem at the level of the body function and structure. Think of the anatomy or pathology or the physiology. So this is an upper motor neuron lesion that is associated with hypertonia or spasticity. You can have contractures of the joints, and you can have bony deformities. That's the impairment at the level of the body function structure. The presumption is that these impairments might lead to limitations in the activity. So what do you do with this physiology? You have a joint range of motion to facilitate walking or running. And that these activities or their limitation is responsible for restriction in participation. Participation is doing the things that one wants to do, attending school, participating in recreation sport, social interaction, being with friends, traveling, if you're an adult, being employed and working. And our treatments are focused at this level, very rightly so. This is where we're trying to make a difference. Now, in cerebral palsy, unfortunately, we have little means to address the primary problem of the brain, so we address the very distal impairments as best as we can. But the assumption is that making changes here, reducing tone, eliminating the contractures, eliminating the bony deformities, will somehow translate into the outcomes that we really want, which is improving walking and running function so that that can translate into the things that children and parents want, that they can participate and lead fuller lives. And these are the things that contribute to what we would call quality of life. But that's personal. What's important to one person may be different from another person. And so quality of life tends to be very individual. So what is quality of life? This is one of many definitions, and the one that I like from the World Health Organization. The individual's perception of their position in life in the context of the culture and value system in which they live, and in relationship to their goals, expectations, standards, and concerns. Okay, so it's a perception of one's well-being. What contributes to one's quality of life? Well, if we had the time and we were in a face-to-face situation, I do an exercise before I show the slide and get people in the audience to shout out what contributes to their quality of life. And invariably, many of these things will be captured. There's family and social life, work life, health, food, drink, mobility, being independent, participating in sports, recreation, having access to education, technology. And then there is where you live. What kind of country you're in, having access to public and civic services, safety and security, financial security, personal and religious rights, justice, equality, the economy, your climate, environment, geography. These things in green are some of the things that we as clinicians might have some influence on. Through health, through mobility and improving independence, maybe we can have a positive impact on these areas. But we need to be humble. A lot of these things that contribute to a quality of life, we simply have very, very little influence on. What we can influence is the health-related quality of life, which are the health-related factors that contribute towards the goodness and meaning of life and how one perceives one's ability to fulfill certain roles. But that's only one small part of the overall domain of quality of life. A very important part, for sure. And health is not just about physical health. It's also about mental, emotional health, and as well as social health. So we have to think about it much more holistically as this definition from the World Health Organization. So what's important to patients and parents? What are the priorities and goals of children and parents, or adults for that matter, with ambulatory cerebral palsy? About 20 years ago, when we embarked on this work, we understood that we had to actually go to persons with cerebral palsy, to the children and to their parents and to adults for that matter, to find out what their perspective was, what's really important for them. And in that work, we came up with this priority framework, which in the center has the population of interest. In this case, let's say ambulatory cerebral palsy, GMS level 1, 2, and 3. What are their priorities, their concerns, desires, needs, and expectations, and therefore their goals that are born out of their lived experience? The only way to determine that is through qualitative work that involves talking, speaking to persons with that lived experience to understand what their perspective is. We also have to determine that there are multiple perspectives. There's clearly the parent who has a perspective that may be very different from the child. When the child is old enough to share their perspective, there may be quite a bit of convergence there, but some divergence. There is a family perspective. What's good for the child may not be good for a sibling, and so on. Then there's a societal perspective as well. And these perspectives may be convergent, but they may also be by divergent. If we understand the priorities and goals of this population, we can then come up with the interventions that are necessary to address those priorities and goals. And by interventions, yes, they are our medical, surgical, and therapeutic interventions, but we can think much more broadly. It could be in the form of legislation and policies, programs and services, technology, architecture, and so on. But once we come up with interventions, we want to know, are they worth it? Do they actually work? You know, we need to test them. Do they actually address these priorities and goals? So we can do that through research with clinical trials, cohort studies, or program evaluation. But how do we prove that this is addressing these priorities? You need to measure outcomes. Outcomes are what define and measure that success. And there's a whole science in developing these outcome measures to evaluate effectiveness. But if the intention of an intervention is to address a priority or goal, then the success of that intervention must then be based on whether that intervention actually achieved those priorities and goals. So it stands to reason that any outcome measure must incorporate those priorities and goals, embed them within that measure. Otherwise, you don't know what it is that you're actually measuring. So let's talk about outcome measures for ambulatory cerebral palsy. And there are several good ones, in fact. And we'll go through these in a little bit more detail in the next 2 or 3 minutes. There's gait analysis, there are gross motor function measure, the GMFM, there are some patient-reported outcome measures that are generic or even condition-specific for cerebral palsy. Let's take them one by one. Gait analysis. We've already heard that gait analysis is a very, very important tool, whether it's by video or a 3-dimensional gait analysis in a motion laboratory. We know that that's the best objective measurement of the impairment. You know, as you can quantify the gait abnormalities by the kinematics, the kinetics, EMG, and the energy expenditure. And that is very useful. And then these complicated, measurements can be distilled into a single number with these various gait-derived indices, which quantify how abnormal the gait pattern is from a typical adult or child without cerebral palsy. It's a single number that the bigger that number, the worse that gait is. Okay. So gait analysis may be the best objective measure of impairment. It's clearly very useful in the identification of specific and complex gait problems that can help guide with decision making. But how well does the conventional gait lab represent or capture the real world? In the gait lab, you're walking for 10 meters in a straight line, back and forth. I challenge you, in real life, it's very seldom that you have an opportunity to walk for 10 meters in a straight line without having to turn left, step over an obstacle, stop to talk to somebody, and then you have to deal with some stairs, you have to turn right, you have to turn left. So there's uneven ground, there's slippery surfaces. So the gait lab captures walking in a very idealized situation. It's very useful, but it's not representative of what happens in the real world. And how valid are these summary numbers? They're a very useful measure of, whether you're making a difference from a worse gait to a better gait, but it doesn't tell you very much beyond that in terms of what really matters to kids and their parents. So how do these summary scores actually correlate with what patients' parents' perception of their outcomes are? Let's talk about patient-related outcomes. You've got the gross motor function measure that's well validated and widely used. This is a 1-hour test done by physiotherapists who test the child doing all of these particular functions. And these are the ones that perhaps you're most interested in: standing, walking, running, and jumping. It's a well-validated measure, but it measures capacity or capability rather than actual performance. So it's an assessment of what they can do when observed by a physiotherapist, but that doesn't necessarily mean that is what they actually do in real life. So it doesn't necessarily translate into those activities and participation in the ICF model that we're really interested in. What about patient-reported outcome measures? There are some generic measures of physical function, like the pediatric outcomes data collection instrument or the activity scale for kids. There are even cerebral palsy-specific measures of gait-related function, like the Gillette Functional Assessment Questionnaire and the Functional Mobility Scale that have all been validated. The FMS, for example, is very elegant for 5 meters, 50 meters, and 500 meters, which represent in the home, in the school, in the community. There's 2 things you have to ask. Can that child do it? And if they do it, what kind of walking aid do they need in each of those environments? So do they do it independently without any walking aid, or do they need a wheelchair for that? And that's scored from 6 to 1 for each of those 5 levels. So all it captures is, for those 3 distances, what kind of walking aid they do. It doesn't talk about whether they are tired, what it looks like, what it feels like, whether they have pain. So it is very useful, but very limited. And if you look at all these outcome measures, none of them ever bothered to actually incorporate child's or parents' goals. Even the CP-specific measures like the FAQ and the FEMS did not actually interview patients and parents and ask them, what is it that you want? And this is something that we decided to do because a few years ago, we were doing a randomized trial looking at whether gait analysis makes a difference in terms of the outcomes. It was a pilot trial just to determine which outcome measure we should do for the definitive trial. And we had all these other outcome measures that we used. And at the end of the study, I had asked children, do you think your operations helped you? And some of them would say yes. And when I asked them, how has it helped you? They gave me all kinds of answers, many of them which sounded very useful and indeed meaningful, but none of those things are being captured by any of the outcome measures that I just mentioned. Even if you put them all together, many of those items are completely missed. So that's what gave us the impetus to say, we need to go back to the drawing board. Now, we had some experience doing this for non-ambulatory cerebral palsy because at the time, there was simply nothing in that was out there that was specifically for the non-ambulant child in a wheelchair who's reliant on a caregiver for their activities of daily living. The GMS is level 4s and 5s. And our work that preceded this and the development of the CP Child Questionnaire gave us a very good model to replicate. So we followed this particular framework. We interviewed children with ambulatory cerebral palsy and their parents. And in an iterative way, we established themes and domains and items that were important to them. We would interview another set of children. And then we surveyed healthcare professionals from multiple disciplines for their input and collectively identified the priorities and goals for this particular population and constructed the Gait Outcomes Assessment List Questionnaire, which has 49 items that cover these 7 domains. So what are things that allow someone to be independent in their activities of daily living? Items related to gait function mobility, walking further, walking faster, keeping up with other people, walking upstairs, downstairs, up ramps on uneven ground, slippery surface, that kind of thing. Comfort and endurance, pain that they describe in different anatomic locations, and fatigue, either in the course of active daily living or during recreational activities. Physical activity, sports, and recreation. Our focus has always been on walking, but these children like to bicycle. They like to swim. They like to do gliding sports. They like to do sports or activities like dance and gymnastics that requires balance. They like to climb. So these require different muscle groups. They're completely different from walking. And these are things that are important to this particular population. What it looks like or the gait appearance that we think is only important to parents, it is important to some children, but it's important to many children at some time of their life, especially during adolescence. So what it looks like and how they conceptualize this is very, very important. The use of walking aids and braces and ultimately body image and self-esteem. And the completion questionnaire results in a standardized score, both for the total and for each of the 7 domains, which can give you a number from 0 to 100, where 0 is the worst and 100 is the best. But what is unique to this questionnaire is that for every item, there is a secondary question, which says, is making a change in this item an important goal for you? So here's an example. In the domain of activities, daily living and independence, I've just randomly picked a couple of items. Getting in and out of bed. How difficult is it for you to perform this activity in the past 4 weeks? This child says it's difficult with minimal and they require some minimal supervision for that. These 2 scores are added to give 4 points. And this, they've indicated, is a very, very important goal for them to improve. On the other hand, getting in and out of a chair or a wheelchair is easy for this individual. She can do it independently, and it's not a goal for them. Okay, so that is the basic structure of the goal questionnaire. When you develop an outcome measure, or any measure for that matter, it is a good measure if it has these properties. First and foremost, it has to be reliable. What does that mean? If you measure the same thing on 2 different occasions, and that thing you're measuring has not changed, whether it's a weighing scale or it's the goal questionnaire, if you get a different answer with the 2 administration or 2 tests where nothing has changed, your instrument is not reliable. So any change that you see is completely, you don't know what it means. So that's a fundamental property. It has to have face and content validity. What does that mean in plain English? That the content needs to be important to the population that it's serving. And that comes from the fact that it was derived from that population. And then you can take it back to the population to get them to say, is this important for them or not? So we've done that work. Construct validity is the ability of the measure to prove that the measure is measuring what is important or what it is intending to measure. And I'll explain that when we get to it. And responsiveness. So when something does change between one time point and another time point, whether that's due to the natural history or due to an intervening intervention, the questionnaire or the outcome measure should have the ability to detect that change, whether it's a negative change or deterioration or a positive change or a benefit. So very quickly, I'm going to just share with you some of the results of the testing that we did to prove that the goal questionnaire is indeed a psychometrically sound outcome measure or instrument. So here, because we have a version for children and for parents, usually typically children over 8 or 9, sometimes with their parents' assistance can complete their version of it, and then there's a parent version. And you can see, this is the first administration and the second administration 2 weeks apart for the child and for the parents. And here are the total scores, and here are the domain scores. They're very close together. So the retest reliability, and it's measured by something called the intra-class correlation coefficient, was very respectable, was high for both children and parent versions. So we were very pleased about that. When we interviewed, we asked parents and children to tell us how important all the items in the questionnaire were. So in addition to completing the questionnaire, this is a different population. We said, how important is this to you? And you can see that all the items were above a threshold of importance of just slightly important. And in blue, you've got the children's rating, and in red, you've got the parents' rating, the parents of the same children. And you can see there's a beautiful correlation between children and parents. But consistently, parents think most things are more important than children think. And that's important to recognize. Okay? If you look at it by domain, you can see the same thing. The most important domain, both for children and parents, is what it looks like. Then, of course, it was gait function mobility, body image and self-esteem, and then all these other things. But well above that threshold of 1, which is just slightly important. So that's reassuring that the content was important to this population. If you now compare children scores with their parent scores, so each child and their parent complete the questionnaire separately, you can see that the children's scores are higher than their parents, consistently in every domain. There's a very strong correlation, however, between parent scores and children's scores, an R of 0.86. But consistently, parents rated their children lower than children rating themselves. Okay? There's no floor or ceiling effect. There's a broad range of scores. But what's the implication of this? What it means is that parents judge their children because they're comparing them to their other children who don't have cerebral palsy. They're using their own idea of what their own abilities are, and perhaps they're comparing it to other children who do not have cerebral palsy. Whereas children who were born with cerebral palsy, this is their normal. So they rate themselves higher than what their parents rate them. I like to word it the other way. What children rate themselves is the gold standard, and parents rate them worse than the children rate themselves. And it's important to recognize that. We then said that if the goal is doing its job, then we would find that between GMSS level 1 to 2 to 3, there should be a significant decline in the score. That was our hypothesis. That is one form of construct validity, looking at known groups. And both for children's version and the parents' version, you could see a clear, significant deterioration in the scores from level 1 to level 3. And in this group, we had a control group of idiopathic toe walkers who scored higher than everybody else. Okay, so that was very reassuring. This was replicated in our combined study in Australia that was published from Melbourne by the Developmental and Child Neurology, which showed exactly that same relationship. We also compared the goal with the FAQ and the FMS and showed very strong correlations between the domains that relate to gait function and the FAQ and the FMS. But the FMS and FAQ don't talk about the appearance of gait or body image and self-esteem or pain and so on. So you can't even make those comparisons. But in the like domains, you had the expected correlations that which were also very reassuring. We also compared it to the gait profile score, which is one of those indices of gait analysis. And you could see that as the GPS score increased, which is worse gait, the goal score decreased. So that negative correlation is what we hypothesized, which we did indeed find. So the goal questionnaire, we are comfortable to conclude that the content captures the priorities of ambulatory children and their parents. It's reliable or reproducible. It demonstrates construct and conversion validity when compared to other measures. It has a wide distribution of scores, so there are no floor and ceiling effects. So patients don't get scores clustered to the very high end or the low end. And it is able to discriminate between GMSS 1, 2, and 3. It's also sensitive to change. We have not shown that here, but before and after an operation, it can show positive change or negative change. It's available now in 12 languages, and we think it's the most meaningful goal-based outcome measure that exists currently for gait-related interventions for children with ambulatory cerebral palsy. But what's in it for the respondent? When David completes this questionnaire, that's fine for research. Before and after the operation, you can show whether the score improved or deteriorated. But how does it help David? How does it help his parents to complete it? There is quite an imposition of time and a burden on the respondent to complete this questionnaire, which we can justify for research purposes. But really, completing this questionnaire does not change their outcome. So what's in it for them? And this got me to think about, can we actually use this PROM, or this patient-reported outcome measure, to help guide decision-making, because the PROM captures those patients' goals. So why is that important? We know that children with CP are often candidates for major interventions. The goals of the interventions can be very diverse. In this case, we're talking about gait improvement, optimizing function and independence. It might be to prevent, to relieve pain. It could be to improve health, ease of care, optimizing or maximizing participation and quality of life. And individual patients and their parents can have different goals from other patients and parents, and even two parents can have different goals for the same child, and the child could have different goals from their parents. And there are different treatment approaches for the same goals, each of those with their pros and cons. And those pros and cons might be weighed differently by different patients and parents based on their own values and preferences. So because of all of this, making decisions about treatment is quite challenging for patients and parents, and even for us clinicians. We've got to consider who is making decisions. In the past, it was very paternalistic. You know, I'm the doctor, I'm the expert, I'll tell you what's best for you. But those days are gone or ought to be gone. It has to be a shared decision. We have an absolute essential role to inform patients, to help them make the decision that is best for them. So it's not that we don't have a role to play, it's a supportive role, and in some instances, it may be a bigger role than that. But what do we need to make a good decision? Well, we need information. We need information about the individual's problems and their goals, informed by their own lived experience and from evidence. We need interventions that we can offer them that can address these goals and know about the pros and cons of those interventions. And we need evidence of the effectiveness or the uncertainty about the outcomes of those interventions. And then there's the question of how do we share the decision? You know, how do we communicate this in an efficient and comprehensive way that is not overwhelming? And how can we come up with a process to facilitate what we call a shared decision-making? So the goal questionnaire is an example of a priority-based outcome measure. You know, we used it because it's based on the priorities of children with cerebral palsy and their parents. So CP Child is similar, but for levels 4 and 5. Both of these measures elicit whether making a change in each item is an important goal for improvement. That's a very unique feature of these questionnaires. So the question is, what is the potential clinical utility of that feature? Can that produce value for patients and parents, value for us as clinicians, and what impact can that have on decision-making or shared decision-making? So let's go back to David. What did he want? He wanted to get rid of his pain. He was frustrated about getting tired easily. He wanted to go out and keep up with his friends. He wants to play more. He wants to do less therapy. He wants to trip and fall less. He wants to get rid of his braces. He wants to look less different from others. He wants to stand up taller. He wants to get his heels down and stop in-toeing. And if you ask him, he's less concerned about his walking. He wants to keep up with his friends. He actually doesn't mind using a wheelchair, at least under certain circumstances, but that is something his parents are not very keen about. So there's a difference there. The parents want David to rely less on walking aids and to preserve his independence. So here is some examples from the GATE Outcomes Assessment List questionnaire that David would have filled out. You can see that walking for more than 250 meters in the domain of gait function mobility was extremely difficult, as was walking for more than 15 minutes or walking to keep up with others, walking faster. And this required a wheelchair for that distance, to move that distance. And to keep up with others, you need a wheelchair, okay? And these were the important goals. He wanted to keep up with others. He wanted to get around more easily at school. What about in the domain of pain, discomfort, and fatigue? Here we're capturing how frequently they have the discomfort, whether it's the foot and ankle, in the lower legs, in the knees, in the thighs, the hips, in the back, feeling tired while walking, feeling tired during recreational activities. And again, you can see this is where the problems are, and these are his important, very important goals to improve those areas. In sports and recreation, he had some goals to help ride a bike better, to help with his swimming, and even to participate in some sports that require jumping, which he used to be able to do about 3 or 4 years ago. How about the gait appearance? He was particularly interested in getting his feet flat on the ground, walking taller. He didn't want to drag his feet, and he wanted to avoid tripping and falling. He wanted to get rid of his braces. And in terms of body image and self-esteem, these were the areas that were his important goals. So we are in the process, and already have, in fact, developed an electronic version of the goal questionnaire that can be completed prior to a clinical encounter. The parent can do their version, the child does their version, and before they see us. And when they submit, it instantly generates a one-page report that provides the total and the domain-specific scores from 0 to 100, which are meaningless to the patient, but it also identifies all the items that they said were important goals under each domain. And this we're trying to make compatible across different platforms and electronic health record. So for David, this is how it might look like. This is the total score, 44 out of 100, and these are the domain scores, okay? More importantly, under each domain, these were the items that David identified as being really important goals that he wanted to make improvements on. With this information, I can now have a conversation with David. I can compare these goals with his parents' goals and reconcile those differences so that we can come together to understand, for this goal, you need this kind of operation. For this goal, you don't need an operation. That can be a modification of your equipment or your environment. So it can help provide information and help fair decision-making. We can also quantify where a particular score might be for that GMSS level on a percentile for a database of all patients who completed the goal in that level. So for David, this is for GMSS level 1. For David, his score was about 44.3, which will put him somewhere at the 35th percentile for a GMSS level 3. So the utility of something like this is that completing it prior to clinical visit, where you can identify these goals and with these reports that then becomes available to the clinician. First of all, it empowers patients and parents to present goals to clinicians so that they know what to talk about. For clinicians, it's a very systematic and comprehensive way to elicit patient-parent goals to guide shared decision-making, and while continuing to evaluate outcomes for research and for routine clinical care. So getting back to David, he has his assessment. He completes the goal prior to his surgery. A decision is made whether to do surgery, what to do, and when to do it. And we can get a measure of his baseline outcome. The intervention is completed, and now we can use the goal to track outcomes to see if the goals were achieved, what were the gains, and what were the losses. So remember this. This is the gains he made, but it came at this price. So these were his scores. Before the operation, he was actually at the 40th percentile for GMS level 3. His total score went from 44.3 to 58, a positive change of about 14 points. In green are the positive changes that were made in these domains. In black, there was really no change. It didn't improve, nor did it get worse. But in 2 domains, it actually got worse. His knee pain went away here, but it was replaced by the dysesthesias in his feet. So a slight negative change, and maybe 6 months from now that will completely improve, but right now that's not so good. And he's not eliminated the use of his braces, and he still needs a walker. So this was a negative change because he actually needs a wheelchair for more. So now we can look at the individual goals and see which ones we actually achieved improvement, and which ones we did not make those gains, and which ones we actually made some losses. So was the right decision made? Has the intervention made David better? Well, the goal questionnaire provides a more meaningful way to define better. It demonstrates both improvement and deterioration, either in the total score, by the domain score, and by individual item or goal to assess both gains and losses. So how should we make decisions? I think really they should be based on shared decisions that incorporate the preferences of patients, parents, and clinicians as well. And we need evidence that intervention can accomplish these goals. That's what the goal can do, and it's an instrument to help facilitate that. So what's the goal? The effective interventions, I think we can agree, should be judged by meaningful outcome measures that reflect the goals and expectations of individual patients. They should be patient-reported. The goal questionnaire does that. The outcome measure must be relevant and meaningful and aligned with the patient's goals. It should be reliable, valid, and responsive. The goal does that. Are we making a difference that matters? We now have the means to find out for this particular population. And can we use this tool to help with decisions? We think so. So the PROM goal can be used both as an outcome measure and to elicit priorities and goals. I think for patients and parents, it empowers them to articulate their priorities and goals from a very comprehensive list that came from them, and it reveals differences between patients and parents or between parents. For clinicians, it's a very efficient and comprehensive way to identify patient-parent priorities, and it provides us an opportunity and indeed the responsibility to respond to these goals. So the value of such a PROM exceeds its utility to track outcomes just for research. It can facilitate decisions about whether and when to intervene, guide the choice of interventions tailored to those goals, manage expectations, improve informed consent. Some of those goals may be unrealistic, and it can enhance shared decision-making. So that's the goal. Thank you. I have lots of people to thank on my research team from Toronto and in Melbourne. And of course, there are lots of groups in North America and elsewhere that are working on validating the EPROMs as we speak. And we've got funding from these sources, the Canadian Institute of Health Research in particular, that I'd like to thank. And this is a link to our website where you can learn more about the goal and lots of the other outcome measures that we've developed for other conditions as well. But I will stop right there. I thank you for your attention.
Yeah, thank you, Unni. Excellent overview of the goal. There are a few questions like, is it available for everyone to use it?
Yes. When we say everyone, there's always a language issue, right? And so it is, we feel confident right now that it has matured to the point that it is worth investing in translating it. So it is already available in 12 languages. The CP Child for non-ambulatory cerebral palsy is available in about 25 languages. We don't have a Hindi version, or any of the regional languages in India. So if anyone is interested, I would be more than happy to work with them. But on our website, you have access to information on how to contact how to contact us, and the methods required to do a translation. It's not just translating, you have to back translate, and you have to culturally adapt it to your environment. And so there's a bit of a process there.
Okay, then there is a question from parent. If the child is diagnosed with epilepsy, spastic quadriplegic, just a minute. So many comments.
I didn't hear you.
Yeah, and at the age of 8, child X-ray shows hip dislocation, left leg. Doctor recommended for hip reconstructive surgery. Some doctor asked to go for abductor. I think that's not relevant to our discussion.
It isn't today. Relevant, but because that I think is more relevant for a non-ambulatory child, and the CP child questionnaire is more relevant to that. And I'd be happy to answer that offline for sure.
Yeah. Then there is a question like if the expectation of family is more than what we can offer, how will you answer that or answer that family or explain?
I think with empathy and compassion. It is understandable. You know, parents want the best for their child, and their first wish or desire is to remove the cerebral palsy, which is not possible. The next is to say, okay, I want them to walk like every other child. So it takes time. This is, I think it is our responsibility to have an interaction with them that allows them to take their time to get to the point where they have learned to accept what's possible and what's not possible, to appreciate the things that they have, the things that can happen. And, walking is about getting from A to B for the purpose of doing something at B. And there are other ways to achieve that without walking. Walking is very important, without question. That's why we do all of the intervention, but that's not the only way to get around as well. So it takes time. And I think, I don't have to tell this audience, perhaps we all have our ways of guiding parents through that journey to get to a point of where their expectations can be more realistic to what it is that we can achieve.
Yeah, Mowli.
Yeah, that was a great talk. The main issue many times it happens so that being doctors, we know the natural history of certain conditions, while parents are not aware because they have not seen those circumstances. And there comes the disparity between their expectations and our explanation, how we can explain to them what they have never seen, For instance, for example, a child with a GMFCS, a bad GMFCS3 with adolescent, they are going to lose there's some functions. So if we do some intervention and they remain static and their outcome, they feel that surgery has not worked. But actually, you understand what I mean. So how do you explain to your patients about this? So how we should explain?
This is what you're referring to, Pawan.
Yes, exactly.
Yes. So I think that when we developed the goal questionnaire, we asked parents and children what their priorities were, absolutely. But we have to acknowledge they can only express their priorities of what they've experienced up to that time point. They don't know what's coming ahead. So by making sure that we've got the perspectives of a wide range of kids of different ages, including adults and parents of these children, we can get that longitudinal history. But we also ask healthcare professionals because, as you very rightly pointed out, we have a knowledge of the fuller population and the natural history of what can come. So it is absolutely vital that we do have a role to play. So this is why it is not as simple as saying it's their decision, you pick. No, that's why it's a shared decision that is greatly influenced by our knowledge of the natural history to guide them through that course. Because as you rightly pointed out, starting adolescence, many of these kids deteriorate. And so preserving their function is actually a success. But you only know that if you had a control group that showed that decline. Similarly, in this younger age group, no matter what you do, they're going to improve. That could be the natural history rather than the benefit of some intervention. So you've got to recognize that, because many patients will seek treatments at this time, all kinds of treatments that there have no objective evidence, scientific evidence to support, and they see improvements, and they attribute it to those treatments that cost a lot of money, when indeed it is no different than just the natural history, where their gross motor function improves in those first 5 to 6 years of their life. So this is really important, understanding that natural history.
Okay. Then one more question, like what you learn by using gold, that which surgeries are not really meeting the expectations of family.
Yes, I think, Dhiren, I think that information will come as we use it more. So, because what I think we are discovering is that we make gains in some areas and we lose in some other areas. Overall, there may be a higher score. So ultimately, that's why I asked that question. Was that the right decision? Is David actually better? That is for David to decide. But when we get a body of evidence from multiple institutions using the GOLD questionnaire, so now it's being routinely used in many centers, we will then be able to answer your question more specifically, where we can say, under these circumstances, this operation, more often than not, does more harm than good, so don't do it. We can't say that yet because it hasn't been around long enough.
Okay. Then there is another observation that in a crouch gait, when we operate and we make them upright after surgery, but their walking speed diminishes after surgery. I'm sure that you must have seen also this in some of the patients. So Yes.
So David is a good example of that. He walked straighter. His knees were straight, but he was walking slower. Now, in our experience, those outcomes continue to increase and improve at 12 months, sometimes up to 2 years. So that may not be the end of the story for David. So I think that taking somebody out the crouch position provides a lot of benefit in terms of taking away their pain and preserving their ability to walk. It may come at the price of walking slower, hopefully for a short period of time, till they regain that strength that that they lose during that recovery period. Usually anti-crouch surgery is very effective in restoring that speed, because they get, once they work a lot less when their knees are straight. But they have to recover their strength to get to that point.
Okay. Now your team has developed it, so you and your team is well versed with that. But say, like, if I want to start using it, how much time my team would take for like carrying out one assessment of GOLD, pre or post?
Right. So I think the most efficient way is for them to have it before they see you. It's like a pre-appointment assessment, or ideally in the setting of the gait lab, if you have one, or a video lab. So if they're getting a formal assessment of their range of motion by a therapist and or a gait assessment, then it's a package. At that time, they get to complete the question as well. That's how institutions are using it at the moment, because it takes time. Absolutely. It is not practical for you to do it in the clinic in front of them. First of all, they should do it on their own. And it's not practical for you to look at the entire questionnaire, which is why you need that one-page report. You can have the raw data in the background, but that one-page report summarizes what you need to know, including their goals, which can then allow you to have that discussion. What's realistic? What's unrealistic? What kinds of interventions can address those goals? And when is the best timing to do it, based on a natural history and so on. So, first of all, you need to be familiar with it. The language, of course, is an issue, but eventually the hope is that the parents will find it useful or worth their while, because you are responding to the goals that they've identified. If you just fill them, they complete it, it generates a score, they're just going to think it took half an hour. What was the point of that? it's important for you to then actually act on the information that it provides. Then it becomes worth their while.
Okay. Then there was a question from one of the participants that at what age earliest we can use goal? It's for the ambulatory children. So like, can we use it at 3 years, 4 years?
Yes. I mean, we in our validation, we went as low as that. Obviously, the children cannot report their priorities at that age. Typically, we find that when they're 8 years or older, but there are some 12-year-olds who cannot do it. Even though they're ambulatory, they may have some learning difficulties, etc. Some of them might do it with the help of the parent. So you have to individualize it. But the parent version, you can do it as early as 3 or 4.
Okay. But when parents help the child to complete the goal assessment, there will be an influence of parents in that scoring.
Yes, that is true. So we ask, did you do this on your own, or did you get your parent to do it? What we tell the parent is to say, when you complete your version, it's your priorities. When it's your child's version, you are filling it for them, but you want to get their opinion. That's what we ask them to do.
Okay. So I think that we have covered all the important questions. Yeah, Maulin, would you like to ask?
I think it's a great beginning of something, and many of us would adapt into our clinical practice. And many times, being surgeons, we are so happy. And at the end of a year, we see that family is not that happy because functionally the child is not well. And I congratulate Unni because we have to be honest to ourselves that many times the appearance has improved, but functionality has not. So this talk has a valid point, and we all are immensely benefited by this concept. And maybe it needs multiple interactions to apply this. So thank you, Unni, for your great talk, as always.
Yeah. Before I pass a vote of thanks, there was a question. Is it the same questions which parents and the child answers? I think yes, it's the same.
It is the same. Yeah.
Same. Yeah.
We just simplify the language for the children slightly.
Yeah. And just a last question, like if we want to start using it, what will be the best way to do it? Like we need to train few people across India, or like the whichever center is willing to adopt it, we need to give them the goal assessment tool, and then they read and then they start applying it. Which will be the best way?
Unlike the GMFM where someone has learned how to do those, this is a questionnaire, a survey. Let's say it's translated into Hindi, then you have to make sure that people who can read it, understand it, it's in a language that they understand, and just completing a survey. And then you have to have a way to generate the scores, and the electronic version of that will help do that. So they can do it on a laptop or on it's a web-based version, which then automatically scores it. We're developing an app on a mobile application as well, and eventually when other languages are available, then we'd like to make them available in those languages too.
Another point, like some of the points which you mentioned may not be that relevant from the Indian context, like some outdoor games and like that. Anyway, like say our population is not that sports enthusiastic. So how should we change or modify those points?
So it's a good point, which is why I mentioned that when you translate, it's not just translating semantically, making it similar, but it should also be culturally adapted for what's important. So maybe your assumption that children in India are less interested in sports may be wrong. I don't know, but they may be interested in different kinds of sports. So the examples that we give might have to change. That's one example. But even in the other parts of the world, not everybody's interested in sports. So if they're not interested in the sport, they can say it doesn't apply. In which case, it can still, so that's we are full. The questionnaire allows people to say they're not interested in, X, Y, or Z as far as the sports and recreation are concerned. But if they are, then we should know about it. Because if it's something like bicycling, then that we have to think about, what's necessary to how to do that, because that may be one way for them to get around a little bit more easily. Or, so it's possible to adapt it, to create those sports when we give examples. Currently, Goal doesn't mention cricket, but maybe we should.
Right. Yeah. So thank you very much, Professor Unni, for sharing your vast experience. And I know that this is a topic which is very close to your heart. And for last 8-10 years, you are working on it, and now you are with this assessment. So I'm sure that the colleagues in India would also start using it. And then we will, whatever question we have or the concern we have, we will come to you for your advice. And I'm sure that definitely we will be able to bring some change in the management of cerebral palsy children. Thank you once again for coming to Indian Academy of Cerebral Palsy.